I figured it out.
It's okay.
Thank you. So, why are we having this? Well, the topic of reaching zero dose in Gavi 5.0, pretty big. And we know that health services, struggle. It's a big challenge to get to the last kilometer or the last mile, depending on your metric system. And so we've often thought about it. And then over time, we've had observations. We know that some of our countries use CHWs as vaccinators. But also for a whole range of activities in health promotion, demand generation, etc. So curiosity was triggered, and at the secretarial level, Alex often reminded us, okay, we don't really have a clear position, but at the same time, some work happened, and today is going to be an opportunity to hear from the work of Village Reach and other colleagues about what's gone on. More recently, we had a World Health Assembly forum on community health workers that was broader than immunization, but Gavi was a partner, and we definitely included it. But today is really focused on CHW's role in immunization, and Tom has been, we've been pushing that forward. I think there's growing interest. I think Antoinette, as our regional head, has kind of formed a group. I don't know if it's an official group or if it's an ad hoc informal group, but really pushing and asking questions about CHW role, and our civil society engagement colleagues are also trying to do a lot. So that seemed like a lot of justifications. And of course, HSIS is going to have a new head of the Expanded Impact program, equitable immunization program, and integrated service delivery. So this seems like a good time to kind of get up to date with the work notably done by Village Reach. So I'll hand over to you, Tom.
Thanks so much, Eric. So I thought we could start by actually talking about what Gavi is already doing in this space.
Are you recording?
Yes, it's recording. Thank you. So one thing is just investment in country-led community health strategies. Gavi funds the technical assistance needed for countries via our alliance partners to develop their community health roadmap, strategy, work plan, and monitoring evaluation frameworks. We're seeing an increasing demand from countries to invest in community health workers through HSS and EAF grants. Gavi has supported community health workers more directly in selected countries, especially in terms of salaries and paid incentives for their contribution to immunization, and in funding innovative training for community health workers. So far, we've invested more than $12 million for community health workers in South Sudan, Ethiopia, Liberia, Madagascar, United Republic of Tanzania, Cambodia, Djibouti, Burundi, PNG, and Uganda. And Gavi's requirement to allocate at least 10% of the combined HSS, EAF, and TCA ceilings for implementation by CSOs has led to an investment of more than $169 million allocated so far to CSOs. And a large portion of that goes towards community engagement. Often that is done through community health workers. And about 50% of that funding is going to local organizations. Gavi's SFA funding also supports implementation research to test approaches and strategies to address safety issues faced by the health workforce, including community health workers. Another thing we're doing is just making professionalized community health workers the norm. Gavi promotes professionalization of community health workers and two-tiered community health worker models like Ethiopia's Health Extension Workers and Women's Development Army and the Care Group approach, which I'll talk about a bit later, as an ethical and cost-effective way to simultaneously professionalize community health workers while continuing to benefit from the volunteerism that we see in communities. And we believe that vaccinating community health workers should always be paid. And we also do some work in terms of tracking progress of community health worker programs. For example, we use routine secondary analysis of human resources for health data to track our resource allocation to community health workers. I want to take you through, first explain who our speakers are, and then after that, take you a bit through the run of show quite quickly. First of all, Rebecca, I believe you have your camera on, but do so if you don't. Rebecca Allman, MPH, is a senior manager on the health systems team at Village Reach. And she manages the organization's human resources for health portfolio, which includes projects related to capacity development, community health workers, and workforce development. She also represents Village Reach and the Community Health Impact Coalition, or CHIC. Rebecca has designed, managed, and implemented global health projects for over 10 years and has specific technical expertise in health supply chains, community health, immunization, and HIV/AIDS. Rebecca has been engaged in research and advocacy related to leveraging community health workers as vaccinators for the past 2 years, and she'll be talking to us about what she's found. I also believe Chifuniro is on board. If you are, you can open your camera temporarily. Chifuniro Chiyendausiku is a disease control surveillance assistant at Wandakweza Health Center in Madisi Dawa District, Malawi. She was initially trained as a primary school teacher, but was drawn to healthcare due to her passion in the field, and she has since pursued a career in the health sector and currently has dedicated herself to providing quality healthcare for her community. Her motivation for becoming a community health worker stems from her desire to help others and to address healthcare disparities in her community. And she felt inspired to offer support and to give back to others experiencing similar difficulties after encountering health challenges and social factors that influenced her health during her own upbringing. So welcome both to Chifuniro and Rebecca. So now what we'll be doing is having presentations on community health workers as vaccinators, both from Village Reach and from Chifuniro as our voice from the field. We'll be taking questions and answers from you to the presenters and looking at just how this might work in Gavi a bit there. And then we're going to be examining some system issues to consider, such as what are the supply and cold chain issues that Gavi countries and partners seem to take into account when using community health workers for delivery of immunization services, the health system anchoring, what are the practical necessities and recurrent challenges that Gavi and countries will need to consider, and the social anchoring, which community health worker systems are most helpful for increasing vaccination demand and what needs to happen to scale those. Then, if we have some time remaining, we'll also return to Gavi countries' perspectives and discussion. We'll probably do that a bit earlier in that Q&A, just to ensure we get to that before noon, in case some of you have to sign off at that time. And then we'll have a closing. Thank you very much. And so I'm going to pass it over now to Rebecca at Village Reach to talk to us about their work.
Great, thank you so much, Tom. Just got my slides up. Thank you for the introduction and again for the opportunity to speak to you all today. It's a topic that's close to my heart, so I'm very happy to be here for the conversation. I have a short amount of time, so I'm going to dive right into the add on to a few of the words that Eric was mentioning about the problem that we're trying to address and why we're here today. As many of you know, the routine immunization coverage is stagnating, has been doing so for around 10 years. And then with COVID, it was further exacerbated. And looking into the future, with additional vaccines such as malaria and HPV, we have actually more vaccines that we'll be needing to administer throughout the life course, not just at the pediatric phase. And at the same time, compounding this, we have huge human resources for health problems in most of the countries that we work in. So the situation we find ourselves in is that we have more vaccines to administer than ever and not enough healthcare workers to deliver them. So that's why I feel like this conversation today is really timely. I'm glad we're here to be talking about new types of strategies to increase vaccination coverage and equity, and particularly how we reach those zero-dose kids at the last mile. And I did want to make a shout out to some new enabling technology that can also help to this conversation. Vaccine patches are now on the brink and could also be game changers in terms of enabling administration for community health workers. So I'm really glad we're here gathered to talk about this strategy. In this slide, I wanted to address why we think community health workers are well suited to play a role in immunization. First, by definition, community health workers live in and are trusted by the communities in which they serve. They bridge healthcare gaps and have a really unique ability to reach folks who may not otherwise be connected to health systems. So looking again at those last mile zero dose populations. They often engage in health promotion and health education activities related to immunization already. So they're generally part of immunization teams, but play a supporting role. And actually, anecdotally, we've heard, and this is something I'd love to add to our discussion session later, that there are many community health workers out there who are actually administering vaccines, even though it's not officially part of their job description or their role. Because they're there and they're part of the team, they see that need, and they want to contribute, and they're physically standing there watching. So I'd love to hear from other country-based folks about what they hear on that. And then we also know that community health workers, in order to be successful, they need to be supported. They need training, they need supervision, they need compensation, they need supplies. So that, as Tom mentioned, is an important part of this conversation of support and systems that need to be there for community health workers to set them up for success in this role. In terms of the question around community health workers and their ability to inject, there is well-documented research through studies that have already been done showing that community health workers are very capable of injecting safely and are actually already doing so with injectable contraception. They've been doing that for many years. And actually with immunizations, community health workers are vaccinating currently in at least 20 countries, according to the landscaping we've done. And countries like Malawi are actually doing it at a national scale. So that's why I'm going to be speaking specifically about Malawi. So these are just some of the reasons why community health workers are well positioned to be administering vaccines. In this last red block on the slide, however, I did want to highlight barriers, which are very relevant to our discussion today as well. In that, the first is that the policy, the legal framework is that in most countries, it is not legal for community health workers to administer vaccines. So there would need to be some shifts in policy and scope of work. And the other is that we are lacking at a global level guidance and best practices that can guide governments and implementers on how to successfully deploy community health workers as vaccinators. So putting together the research and best practices to figure out really the best way to do this that is currently lacking. So because of the lack of research and evidence that's out there globally, actually Village Reef decided to do some of our own research to pull together what is there now. So we did a rapid review of community health workers as vaccinators, and that was published in Global Health Science and Practice. And what we learned is that community health workers actually administer vaccines in 20 countries that are highlighted on this map. And if you take a look, that you'll see that all 5 of Gavi high impact countries are highlighted on this map. So that in these places, community health workers vaccinate to varying degrees. Some it's through a small selection of vaccines, some do it in a smaller geography, and there are a handful in which they actually do it across at a national scale. And as I mentioned, Malawi is one of those, which is why we'll dig a little bit into Malawi now. So a little bit of context around Malawi. Their community health workers in Malawi are known as health surveillance assistants. So you'll hear the acronym HSA. And they are, as I mentioned, one of the few countries across the world that use community health workers as their primary vaccinating cadre across the country. HSAs get 12 weeks of initial training. They are employed and salaried by the Malawi government, which is an exception among most community health workers in the world. And they carry out key tasks like health education, family planning, childhood analysis, MNCH, a lot of the typical community health worker tasks, but a significant part of their role is actually administering routine immunization. And again, not supporting, but actually doing the injecting. And in Malawi, HSAs are estimated to administer at least 80% of the vaccinations across the country and have actually been doing this for decades. Since the 1970s, starting with smallpox, community health workers were brought on board to do those vaccinations, and then over time have added additional vaccines, and now they do all of them, even including malaria, HPV, COVID-19. So that's why, again, Malawi is a really interesting case study to look at how they're doing this and potentially what other countries could learn from their experience. So that's some of the research that Village Reach did last year. We conducted a qualitative study to describe and assess the role of HSAs, health surveillance assistants, as vaccinators in Malawi to inform recommendations for other health systems. And a big part of that study really was documenting from top to bottom the programmatic and kind of operational roles that HSAs play, and how the health system supports them in that role. So everything from how they are trained, how they are supervised, how they maintain vaccine safety, what is their role in the cold chain. So we want to share some of those findings with you today. So what we learned about HSAs and their routine immunization responsibilities is that they in preparation as to become an HSA, you have to undergo a 12-week training prior to being allowed to administer any vaccines, and that includes both theoretical and practical. And when any new vaccines are added or protocols are changed, they're called together and they get a short briefing or training before moving ahead. They're also trained to they're trained to administer vaccines in a number of different settings. Some are based in a clinical setting. They often do outreach in a community setting, and they also do campaigns for non-routine vaccines. So there's a few different scenarios in which they administer vaccines. They also do community engagement, and I don't think I'll have time to go through these line by line, but we documented how demand is created through education sessions, fielding questions from community members, how, again, vaccine safety is maintained through, for example, checking vaccine expiration dates, vaccine vial monitors, monitoring adverse events, and also how they participate in the supply chain. For example, what types of forms they need to fill out, what calculations that they do to determine demand, and again, their role in the cold chain, what equipment that they use, what they're equipped with, how they go out, prepare vaccines for outreach sessions. And one of the highlights from our research actually really showcased the importance of the supervisor role. So we also documented their role and how they support HSAs in vaccination. So again, I won't have time to go through these line by line, but they're very important in terms of maintaining quality for the activities that HSAs carry out. So they do a lot of direct observation of the vaccine administration, making sure that expiry dates, vaccine vial monitors, all of the kind of quality control checks are done. Advising on cold chain practices, ensuring that the fridges are working properly, organizing logistics and transport of the vaccines, and of course, serving as that overall supportive role to answer questions and mentor HSAs. So some other key takeaways from our research. One of the first, and I think most important, is that this research really showcased that this approach can successfully be carried out at a national level. Community health cadres can successfully be trained, supported, and supplied with products to support routine immunization. But the key caveat is they need to have the right supportive infrastructure in place to do that, to set them up for success. And I know that's a big part of the conversation that we want to have today. One of the key benefits of Malawi's model that really came out in this research was that HSAs provide what we termed wraparound immunization services, meaning that they kind of provide the whole package. They do the registration, they do the administration, they handle referrals, and they do that without the presence of nurses or other health workers there to support them, which clearly has a big HRH benefit. There's no nurses there that need to supervise, so it frees nurses up and other health technicians to handle more complex medical tasks in a clinical setting. And the last piece is around trust. And that's something I know, through COVID, we've learned more and more how important that is for demand generations, is that HSAs are viewed by the community as trusted vaccinators and service providers. I just pulled out a quick quote to demonstrate that from one of our key informants in the community. They said that if another person goes there with the vaccine, people will not receive it. But if it's an HSA, they say our doctor has arrived. So that really showcases how they have full trust in community health workers to vaccinate them. They have really no hesitation in receiving vaccines from their community health workers. In fact, they welcome it. Okay, and for my last slide, I compiled some kind of global level recommendations that we took out from our Malawi research that can be translated into other settings and hopefully teach other countries how they could implement this approach, and sort of what are those key prerequisites that we saw that need to be in place in order to make this approach successful. So the first is around supervision and the need for what we call dedicated supervisors to be there to coach and mentor community health workers to vaccinate. And by dedicated supervisor, we mean somebody that's supervision is actually their job. It's not just a nurse or someone in the clinic that's kind of been added the task of being a supervisor and who's really busy with a million other things. It's somebody whose job is to supervise. And as I mentioned, that's got a lot of implications in terms of quality control and making sure that the vaccination is happening safely and HSAs are getting the mentorship that they need. The second is around human resources. Again, that idea of supporting community health workers with the compensation that they deserve. We believe that community health worker pay should align with the workloads that they're doing and really recognize the valuable skills and contributions that they're making to immunization. And community health workers in most countries right now are not salaried, so that's an important point. Also related to human resources is the workload. I mean, we all hear all the time about how community health workers are being tasked with more and more things that they can handle. So ensuring a reasonable workload for community health workers who vaccinate is a really important HR consideration. It's not a task that can be taken lightly. It's not something that can be easily tacked on to a job description for a community health worker. It's quite a significant task. And so there needs to be a lot of planning and task shifting to ensure the workload is reasonable for a community health worker. Next, around training, not surprisingly, we recommend an extensive introductory training. So before anyone is able to vaccinate, that needs to be thorough and both practical and theoretical. But it should also be coupled with routine refreshing type trainers so that you're not just trained once at the beginning, but that they're throughout your career, you have refreshers and reminders to keep those skills fresh. And that the training should definitely include things related to supply chain. So cold chain, vaccine waste management, inventory management. And I highlight that because that's something that we don't always see in community health worker trainings. And the last pillar here is around supply chain management. We did see a lot of complications related to support, getting supplies where they need to go, particularly budgets for fuel and things like that could really be bottlenecks for getting vaccines where they need to go. So a strong recommendation for budgets that include transportation, fuel, maintenance for vehicles, and obviously the cold chain equipment like cooler boxes for last mile transportation of equipment by community health workers. So yeah, I think I'll finish there with some of those global recommendations, and we can move back and touch on some of these things in our discussion. Thank you so much.
Thanks so much, Rebecca. I really appreciate that. When you were speaking, I was thinking about when I was with World Vision, and they were working with 186,000 community health workers. And the question came up as if they could intervene in a new area, which was child protection. And a lot of people were kind of second guessing and saying they won't want to do this. They're not going to be able to do this. It's not safe for them to do it. And so we actually did a survey, and what we found out is they're already doing this. They're just not well trained to do it. And they felt a real, like they see needs and they respond. And so I'm sure that there are community health workers already involved in vaccination that are flying below the radar a bit. And I would think one of the priority things we need to do is make sure all of them are getting paid and trained so we can assure that they're doing it safe. So now I want to shift a bit and hear from a community health worker, Chifuniro Chiyendausiku. She is now on the line. If you want to go ahead and put on your camera, Chifuniro, and I was going to ask you several questions. Good morning.
Good morning.
Yeah, thanks for reaching us. I know you're in Malawi now, correct?
Yeah.
Wonderful. So maybe we can start by just asking you, how do you think that community health workers can be better leveraged for demand creation for vaccination, and why?
I think that community health workers can be better leveraged for demand creation for vaccinations by making sure that they are getting regular refresher meetings, which will help in expanding their knowledge on vaccinations, and also provision of modes of transport like motorbikes to speed up service delivery.
Thank you. And if you could go ahead and stop sharing your slides, that'll give Chifuniro a little bit larger spot on the screen there.
Excuse me?
Thank you. Wonderful. Yeah, and another question is, what are some of the routine things that you do in your work to promote vaccines, and why do you think that you're effective in promoting vaccination as a community health worker, and possibly even more effective than doctors, nurses, and other staff in that regard?
Okay. Some of the routine things that we do in our work to promote vaccines is by civic educating people on the importance of associated
Sorry,
with
please
vaccines.
mute everyone.
Can I
Go
continue?
ahead, try again. Go ahead.
Okay. And I think community health workers are effective in promoting vaccinations because we reach more people in the community, including those who do not go to the healthy facility because of long distances. So we make sure that we bring the healthy services like vaccines closer to them at the communities. And also another thing is the trust the community members have in us as CHWs, since we spend most of our times at the community with them. So we know them better, sometimes by name, and they know us, they are used to us. So they have their full trust in us to be the ones to be providing these vaccines to them.
Great. Yeah, that trust, I think, is a really key thing. And it's hard for people to have that trust if they don't have a lot of contact with people. And that's one thing that community health workers are able to do. What do you feel like? So you're in Malawi, one of the countries that has probably scaled vaccination by community health workers more than any other, as far as I know. What do you see as the challenges that community health workers face when administering vaccine?
Okay, there are quite some challenges that community health workers face when administering vaccines. The first one is misconceptions and religious beliefs. Some people have these beliefs that they do not get associated with any medical services. So it's hard to convince them to get vaccinated. And in times of outbreaks, these people are the same people who bring a risk to the other community members. And also another challenge is transport. Most CHWs travel long distances, compounded by rivers and mountains, and sometimes we travel by foot because the push bikes we use are most frequently subjected to breakdowns. So it's hard to reach some hard to reach areas because of the modes of transport we use. And another thing is hectic schedules during campaigns. When we are doing campaigns, it's most of the times it's one community health worker against the whole community, against the whole catchment area you are serving. So you are given specific time to vaccinate the people. They will give you time, days that maybe you should vaccinate all the under 5 children. So with the time and with the population, it gets hectic. And also the biggest challenge that we are facing as community health workers in Malawi right now is untimely payment of lunch allowances. It takes time for the organizations to provide us with our lunch allowances after we are done with the work. Sometimes it even takes years. For example, last year we were providing polio vaccines to all under 5 children, and it happened that I myself I was skipped. I was not given my lunch allowance, and up to now, I tried talking to the members of the organizations, but I've not been helped. So it's a challenge that most of the community health workers are facing right now.
Thanks so much, Chifuniro, and I'm sure we'll be coming back to you with some questions quite shortly. Now what I'd like to do is actually open it up to the other participants on this call that might have questions for Rebecca or for Chifuniro. So if you want to raise your hand. Okay, I've got about, yes, Daniel, go ahead.
Thank you so much, and good morning, Rebecca. Very insightful presentation as you have made. I am more interested in how the system is set up, because this in itself determines how well it can be leveraged. Specifically around the reporting, how they report, the tools they use, you know, paper-based or electronic tools, are they fitted with mobile devices? You know, how is their performance measured in terms of accountability? And then, since this is a government-backed endeavor, are they working parallel? Are they linked to the formal health systems? Is it at the health facility level or probably district level? You know, that setup really. It would be good for you to touch on that so that we can get a clear sense of how best this can be replicated. Over.
Thank you, Daniel.
Thanks, Daniel, for the question. And I'll touch on a number of these things, but we do outline a lot of these factors in more detail in the publication that we put out recently. So I can share the link for that in case you want to take a look and get a detailed look. In terms of reporting and tools, I can generally say that most of them are paper-based, although there are certain parts in the country that are piloting or using digital tools. I'd say most commonly they are paper-based, and they get quite a bit of help from their supervisors in terms of collating data and sharing that data. Maybe Chifuniro can provide more insights on that in terms of the interaction. Performance management was something actually that was highlighted as an area that could be added onto in terms of system support. Supervisors do provide routine mentoring and feedback to HSAs. However, that feedback loop isn't always there. There's not that continued tracking and measurement over time of, say, this is where you were a year ago, this is where, you know, things you need to work on for the year to come. So that being more systematic is something that we highlighted and actually are looking at in terms of tools that we are helping to develop and job aids that Village Reach is working on now in Malawi. And your last question was around overall system setup. So I think I mentioned that community health workers in Malawi are very heavily integrated into the Ministry of Health's systems and tracking, and of course they're salaried. So for example, in some countries we've worked in, it's been very hard to even get a sense of how many community health workers are working in each area. So Malawi is I think a step ahead in terms of documentation of their community health workers, where they are, how long they've been on board, their different levels, different grades that each of them have. So relatively speaking, across the globe, Malawi is documenting community health workers in a more detailed fashion than I think in a lot of other places. And I think a lot of that is tied to the fact that they're salaried. So making that linkage with professionalization and integration with the system. We have looked at a lot of other countries that everything is a lot more disjointed and disorganized and handled mostly by partners, but Malawi's ministry has been very strong in consolidating and having these different data systems to track and be able to support HSAs, both in terms of salary, but also in other ways too. So I'll stop there and then make sure that Tom shares the link to our most recent publication about Malawi.
Thanks, Rebecca. And you could paste that into the chat, Rebecca. And Chifuniro, just touching on that a bit, when you're supporting vaccination programs here in Malawi, are you using any digital tools to do that? Or is it like phone-based or otherwise? Or is it all paper-based for what you're doing there?
So other community health workers in Malawi are using tablets. Like for our organizations, we use tablets to collect data and use it to keep other information about vaccines and our work. But it's just a few districts which have access to these tablets. So most of the times I can say that we use paper-based. We have these registers that we use. We keep our records for the children who have been vaccinated.
Thank you very much. And Jessica, I'm going to go to you now. We'd love to hear from some of our senior country managers.
Thank you very much. And hi, Rebecca. Hi, Chifuniro. Thank you very much for the presentation. I'm Jessica Crawford. I'm a senior country manager for Nigeria portfolio. And I'm also representing Takumbo today as the director of our high-impact countries. Two of the barriers that we hear often with regards to the ability to introduce and scale community health worker programs with particular emphasis on ability to immunize is one around the financial implications of that. So countries really, having sort of fiscal responsibility for increasing the health workforce and ensuring that there is, payment for those salaries. And then the second one being around professional associations and the ability to sort of task shift or blocking the ability to task shift some key responsibilities and scopes of work to community health worker cadres. And I'm curious if you can comment from your research and from your experience on one, how Malawi has has successfully been able to scale a national level community health worker program with those two key aspects in mind. And then if there are any other examples from other countries that that you might have based on your research, I think that can help us in terms of how we interface with our country counterparts and how we sort of approach this overall as Gavi. Thanks.
Thank you so much for the question, Jess. Okay, I'll start with the first issue that you mentioned around pay. And I think for Malawi, one of the key things to mention is that this has been in their national priorities for a really long time. So community health workers have been vaccinating for decades. And so in terms of national priority setting, budget setting, and also looking for outside funding, this has been high on the priority list. And so a lot of that has to do with having strong national level leadership to support that prioritization. And we do see that happening in some other countries now. I'll give Liberia as an example. We know that they have some very strong community health partners that have also been advocating for this approach. And I've heard that there's been both political and also partner commitment to making the shift and having community health workers vaccinate. And a big part of that national level advocacy that's been happening is opening up more budget lines to support community health workers in terms of pay, in terms of strengthening the supply chain and getting all of that supportive infrastructure in place. So as with many things, I think a key factor is having strong leadership and or a couple of champions in the ministry and in partner groups to push that agenda forward. In Malawi, they've had that for a long time. In terms of In terms of task shifting, I mean, that's an interesting question, how professional associations may play a role, but also having the research in place to really be able to make that case is, I think, important. That's something that we're also looking at, is how we can expand that evidence base to be able to show, if this, then that. This is the benefits that you would get as a country if you made this shift, in terms of financial benefits, HRH benefits, and of course benefits in terms of vaccine outcomes, so coverage, equity, and all of those things. So I think something that we're looking to push forward is more implementation research to be able to showcase to ministries, to professional associations, to show what this approach can do for each country. I think I'll pause there and see if there's any other additions that Chifuniro has.
Yeah. Anything to add, Chifuniro, on that? Okay. Yeah, and I was just thinking, I remember reading a study recently, I think you might have shared it with me, Rebecca, that was talking about, at least it was like from the US, but showing a 10-to-1 return on investment from community health workers, and just how much money it saved, like the hospital nearby. And that's something I think we need to document as well. It's not just paying community health workers and their role in vaccination, but what is the overall effect when they're actually working a wash, nutrition, other things, that if they can increase the percentage of people adopting a lot of life-saving behaviors, that's going to also mean an effect on the not needing as many health services at the clinic after a certain point, and also reducing the economic impact on families, since we know that there are a lot of poverty is when people are basically falling into poverty from catastrophic health costs. So something to keep in mind. Ranjana, I'm going to pass over to you now.
Thanks a lot. Thanks a lot. This is really very, very impressive and excellent presentation. I thoroughly enjoyed listening to the experience. I want to go back to that slide which showed a map and the number of countries there presented. And my question is really that, how many of these countries domestically finance the community health workers? And was there a struggle to make that transition from a donor-funded program to a domestically financed program? Thank you.
Thank you so much for that question. I'm just going to go ahead and try to pull that slide up again. And so to your question around the extent to which the countries finance, I wouldn't be able to pull up a statistic on the top of my head, but I do know, generally speaking, across the globe, I would say the latest I've seen is less than 30% of community health workers are actually salaried by the government. Some are paid in terms of getting smaller stipends, but actually being a routine government employee and getting that salary month to month it's a pretty small percentage throughout the globe. So I would say a small percent. And in terms of the scale of that, we do know from our landscaping that in many of these countries, it's small pieces of the country that are doing this. So there have been a lot of pilots that have been sponsored by partners. There have been a lot of short-term initiatives that never really were able to make it to scale. I think for some of the reasons that you're mentioning, either that there wasn't the government commitment, there wasn't that leadership there to be able to take it to scale. So in some of these places, it's exciting because we've been able to see sort of proof of concept at this small scale. But then the barrier is then taking that forward and making it something that's systematic and something that is bigger and across the country. And that there's a lot of reasons for that. And what we've mentioned, those system barriers. So we know in many countries, the community health workers are not well documented. It's largely a partner exercise that's very piecemeal and not always well coordinated at the national level. So I think in our experience, we've seen that across a number of countries. So I imagine that's something that us as partners and donors as well could help to support For example, one of the initiatives we've been talking a lot about recently is the need for national community health worker registries, just a simple system that will put together all of the data for all of the community health workers that are working in one country, to know who works where and who's been paid and what their phone number is. I mean, it sounds like a really basic thing, but most countries don't have that. So even some of these basic infrastructure to help support a more coordinated national level effort, I think could help some of these countries that are highlighted now, being, rather than it being a piecemeal exercise, being something that could be brought to scale.
Thanks, Rebecca. And I was thinking how we really need to remember the role of CSOs can play in this, because some of these community health workers are working directly with the government. Some are working a lot more directly with staff from private, based by INGOs, NGOs, local organizations, and might be coordinating some with the government. But we're going to have to bring those together, and the government should be very knowledgeable about where all these community health workers are, since it's part of their system. And maybe that's a role CSOs can play in terms of documenting where are they, who is paying them, and helping to advocate for training them more so that they're able to play this role. Mwingi, I'm going to pass to you now.
Thank you, Tom, and thank you, Rebecca and Chifuniro, for the nice presentation. I think for me, it brings me now to some of the work that we're doing in system design and integration, and especially hearing from you on how community health workers are doing some of the supply chain activities. Now, just to share with you, we have an initiative which we're piloting in Nigeria, Sierra Leone, and Kenya. And this is what we call DRIVE, that is direct delivery of routine immunization vaccines and other PHC commodities for equity. So basically, I noted also some of the issues that you talked about in terms of lack of transport, in terms of motorbikes, and also some budgetary issues that also Jessica talked about. So we know that, yes, even when we buy motorbikes for the government, the issue is on the maintenance side, and this has been a challenge. So with the DRIVE, I'm just trying to see how we can link this and learn from each other, and how we can make it strengthen the approach better. Is the DRIVE initiative is looking at how do you empower those communities who form small cooperatives, like young people. We buy the bikes, they own the bikes, they maintain them, but then there's an agreement to actually offer some of the services that we've talked about in terms of what community health workers are doing, vaccine deliveries to the last mile, and so forth. So this could be an opportunity that we could look into. Then it's some kind of private sector engagement within the community, and they can benefit from actually having the local people. And in Sierra Leone, I think there's a plan to involve some of the health workers who are not on pay. So this could be, in my thinking, that it could be actually transferred also to community health workers. When they own the motorbikes, they maintain them, and there's a contract that is between them, so they can earn some money at the same time strengthening some of those immunization activities. So I think I'm interested to learn more about this, and then happy to share more on the DRIVE initiative as well. Thank you.
Thanks, Mwingi. Yeah, and I'd be interested to know if that's being done anywhere presently, and whether and maybe from Chifuniro, if you feel that would be a big incentive if there was a way to contract these motorbikes so that eventually the community health worker owned them. Rebecca, we'll start with you.
Thank you so much, Mwingi. That's a really interesting initiative, and I'd love to learn more about it. But I think what your point really makes me think of is that there's just so much information sharing that still needs to be done. I want to just make the caveat that me presenting about Malawi today doesn't mean I'm saying that Malawi is the example that every country needs to follow. It's just the example that we know best and has now been, the first really in-depth country study that's been documented and published. But there are a lot of other things happening and a lot of other interesting innovative approaches like this DRIVE initiative that you just mentioned that I think also we could pull some really interesting learning from. Sharing across different countries, I think, is going to be really key in making this a successful approach. One thing may work in Malawi, one thing may work in Nigeria, but I think the more information that we have, the more evidence implementation research that we can share and put out there in this community, the better. So sharing, the results from this DRIVE study and looking at, having more engaging conversations like this about how those approaches could be applied in other places, I think is incredibly important and a way that we can and should continue this dialogue and not simply focus on Malawi, but look at other countries that are doing this at scale, like Nigeria. I'd love to, have more direct engagement with people working there and learning more about the approach there too. So thank you and look forward to talking more about it.
Thanks, Rebecca. And Chifuniro, I don't know if you have anything to add, especially you had brought up.
Tom, I think you might be on mute. I don't know if Chifuniro can hear you.
Oh, sorry. Did you hear you heard my question though, right?
I did not.
No.
Oh, sorry about that. Yeah, I was saying, Chifuniro, you had mentioned that that transportation was a real challenge, and I wanted to see is your transportation provided or for any of the community health workers in Malawi, or is that something that no one is having assistance in terms of transportation?
Okay, so as in Malawi, we are being provided with push bikes, which we use to transport the vaccines and to go around the communities administering vaccines. So as you know, some places are hard to reach, some places are hilly rivers, there are mountains, and it's hard to reach those kind of places with push bikes. But for now, we do have motorbikes, but maybe just one motorbike at a health facility, which is mostly used by the supervisors, not the HSAs.
Okay, so that might be one way to really extend the reach of community health workers, especially in countries where they're paying them and they want to see an increased coverage there. Tarek, before you had a question, you had your hand up. I don't know if you still do.
Yeah, sure. Thanks, Tom. Can you hear me?
Yes.
Okay. No, thank you. I put my hand down because there was a lot of overlap with the questions already raised and answered. But let me bring in just a couple of comments in case there's any reaction. So thanks a lot, Rebecca and Chifuniro, for the really interesting discussion, and colleagues too. What caught my attention the most, and I'm senior country manager for Sierra Leone, Liberia, and the Gambia. What caught my attention the most is currently in Liberia, we have a lot of momentum to make a transition with high partner interest to invest in community health workers, the platform, and also from the government looking at adding them to the payroll. So what caught my attention a lot is what you said, Rebecca, about the Malawi model with a 12-week training for them to be able to administer vaccines, which is not the case. It's not the role of community health workers in Liberia currently. So I was interested in two things. One is the financial sustainability point that's been discussed in previous questions. And secondly, what kind of data you might have from other research in countries where, like to help make the investment case for countries where community health workers are not actually administering vaccines. If there's information or evidence to help make the investment case for still adding them to the payroll and in making that investment in countries where they're not involved in vaccine administration. Thanks.
Sure, I can react first, and then Chifuniro can comment if she has any other comments. So in terms of Malawi, you mentioned around the financial sustainability and training. So one example I can share to showcase that, there are still financial sustainability questions and challenges in Malawi too. One thing we learned is that the government has actually developed, and they've been envisioning this for a number of years, a more in-depth certification program for community health workers, and that would actually involve a 1-year training, and that curriculum has been developed and they have rollout plans, but they've been trying to get it funded for I think at least 1.5 years and haven't been able to roll it out. So they have the initiative and drive to make this a stronger training program and actually give certifications to community health workers, but they haven't been able to get that sustainable funding in place yet. So that's just an example to say that those issues are definitely there. In terms of the investment case for other countries, I'd actually call out the Community Health Impact Coalition, who we have some representation from on the call today. They do a great job of pulling together research that provides the investment case for paying community health workers and providing them with salaries and remuneration and all the different types of support that they need to be successful, whether they're vaccinating or not, to be honest. But particularly if they are vaccinating. So a lot of that research is there. Like Tom mentioned, there's been studies around the return on investment that you get from community health workers, and dozens of studies that show that community health workers perform better. There's less turnover when they are regularly and fairly remunerated. So that evidence is there, but the evidence is not particularly linked to the idea of community health workers vaccinating, because there are right now a few use cases there in the world that it's being done at scale. And that just brings up the issue that I mentioned before, that this approach is just not well documented in the research yet. So that's another thing that we're working on, is developing more evidence around the challenges, the implications, the benefits, and making that investment case. So we've got a couple concept notes in the works to try to get more evidence out there around that. And I can see that James, who's also on the line, he's the research lead from the Community Health Impact Coalition, is going to share some things in the chat to link people to research.
Right, and it sounds like there's a bit of a circular problem there. We don't have enough community health workers vaccinating, so we don't have enough evidence on community health worker vaccinating that we can use to make the case for it. Chifuniro, I don't know if there's anything you would like to add, especially around training of community health workers in this area. Oh, you're muted.
Okay, as Rebecca already said, that community health workers are trained in Malawi. We are trained, and of course, not all of them who have been trained. Some have not yet been trained, especially those who have just joined. So yeah, for Malawi, the community health workers are trained, and we are certified, and yeah, we're also salaried.
Yeah, and let me ask you frankly, so with that training, did you feel like you came out of it really sure about what your role would be and how to do it, or did it really take a lot of additional supervision and support after that? Because for some things, the classroom training, it's really hard to fully understand it until you've had someone actually watching you and mentoring you a bit.
Okay, so as for me, I've not yet undergone the training. So yeah, I cannot say much about that because I've just joined recently. Yeah.
Okay, got you. Thank you. And Naran, we're going to pass to you.
Yeah, thanks, Tom. I'm sorry if I repeat the question. I joined very late, so if I'm repeating something you said already, please ignore. My question is if there is any case about performance-based payment for community health workers, and who was doing the supervision and how they monitor this work. Yeah, and mainly how CSOs can work also with community health workers. what support they can provide, maybe in supervision, what kind of support we can link both of them, CSOs and community health workers together. Thank you.
I can start. To my knowledge, in the landscaping that we've done in our research in Malawi, I had not seen anything about performance-based incentives, particularly for community health workers vaccinating. I know there's kind of a debate in the community health world about using performance-based incentives generally for community-based activities, that sometimes there's issues with having different motivations that may not have the best results. But I haven't seen anything documented about it, and it's not happening in Malawi. So that's all I can say.
Thanks, Rebecca. What we'd like to do now, we did have some questions that we wanted a few people to discuss. Rebecca, we're going to start with you, but we're going to have people limit their responses to this about 2 minutes so that we have time to circle back to the larger group and ask about things like, what are the research gaps you think we need to advance community health workers? What sort of guidance do we need? Which countries do we have untrained community health workers who are vaccinating in any way? Some of those questions, but let's go ahead and start with you, Rebecca. What are the supply and cold chain issues that Gavi countries and partners need to take into account when using community health workers for delivery of immunization services?
Thanks, Tom, for the question. I can just run through these quickly. I think actually a lot of these have already been touched on in the conversation already, but here's just a quick summary. The first is around cold chain. A lot of community health workers, as they're initially onboarded, get either no or limited cold chain training typically. So if that change were to happen in a country and community health workers were to be given that additional responsibility, there would be a lot of training needs around the supply chain piece. The landscaping also highlighted a lot of equipment issues, so having not enough cold boxes, vaccine carriers, the types of equipment that you would need to be able to have outreach sessions in the community, so just having enough supplies. And in some cases, no, actually that's... So next is around network and transportation, and we've touched on that as well. Community health workers often need to go to collect vaccines and then actually have to bring them back out into the communities. Different countries and even different districts do this in different ways. Sometimes the community health supervisors are involved. Sometimes there is routine transportation, sometimes there isn't. But these distances can be long and challenging. And in Malawi in particular, we highlighted that, you know, each time one of these outreach sessions happened, it was a scramble to see if it was going to be a motorbike, to see if there was enough fuel, to figure out how it was going to happen. So it's getting these logistical routines in place, I think is a big challenge for any country. Community health workers travel by foot, by bicycle, by motorcycle, some even in canoes, and also in public transportation. And another challenge we noted, and Chifuniro noted as well, is that some of these costs are borne by community health workers themselves, whether they, you know, it's for lunch, whether it's for having to take a bus, and not these reimbursement mechanisms are not always there. And sometimes community health workers are paying for things out of pocket and either never getting reimbursed or getting reimbursed a year later. So that was a complaint by a lot of community health workers across the board who do this. Stock management, probably not surprising that there are supply shortages, including lack of vaccines in some countries. This was not highlighted in Malawi so much, but in other countries, vaccine stockouts were a huge challenge, stockouts at the national level, but also for other supporting equipment like medications and gloves, obviously having those in place on a routine basis, and particularly being able to surge those equipment when you're doing a campaign or when you have increased demand, and keeping in touch with what the demand is. That's something we saw a lot during COVID when the demand was rather unclear. So being able to get that data in real time to know how to estimate, how to look at demand for the coming months. And the last is around wastage. A lot of community health workers work in low population density areas, so there are challenges managing open vial wastage. Community health workers sometimes are not clear on whether to turn people away so that they shouldn't have to open a new vial, or how to manage these difficult situations when they know that they have a limited amount of vaccines. Should I open this new vaccine that's supposed to be used for 10 people when I only have 2 people sitting in my line? So a lot of community health workers have that challenge. So those are the main challenges I wanted to highlight.
Great. Thanks so much, Rebecca. And now I'm going to turn to Eric. In terms of health system anchoring, what are the practical necessities and recurrent challenges, especially in terms of coverage, workloads, training, that Gavi and countries will need to consider if we're going to scale the use of community health workers as vaccinators and in promoting vaccination demand? And what maybe are some of our best next steps in this regard?
Okay, so all that in 2 minutes is a challenge.
Yeah.
But I mean, we've had community health worker programs for more than 60 years. And I'd say at this point in our global reflection about how health systems need to support it, I'd say we can summarize it with 2 things. Do we have intentionality? Are we moving away from ad hoc system, or we want somebody to distribute bed nets? Let's build a system for that. We want somebody to promote the next immunization campaign. Let's have a system for that. So we need to be more intentional. Are we building, and Malawi is doing that. Rwanda has done it, not for immunization, but Ethiopia is a case example for other things. So is there intentionality, and is there thinking at scale? And often the issues of cost is because the thinking is not really done at scale. I mean, the point of community health workers and reaching close to communities is to reach that scale. And for Gavi, the zero-dose agenda is really forcing us to that, because it's those unreached children. So if you think about intentionality and scale, it translates into policy and governance. So, what do we want to do? And I'll leave beside the supply chain, which is a big one for scale, but you've just talked about it. But in terms of human resources for health, then it's really this fitness for purpose. What do we want from primary healthcare providers that are primarily in fixed sites, facilities? What do we want from community health workers? And how do we balance the two? And we need to move from having laundry list of what CHWs can do, because there's been some studies somewhere, to having something that fits to the country role and responsibility. Right now, we're trying to do some work, support through our grants in Niger, for example, in trying to think about the balance between routine and outreach or even supplementary immunization activities to make sure who does what makes sense. And the same thing goes for the role of community health workers, because they do more than vaccination, and so it's like, how does it fit? How much do we want to balance? You mentioned the coverage, the geographic coverage, and the registration, the registries, but there's also the time management, and this is a measure of management or even governance. That spend 20% of their time on immunization, can it be integrated with something else? Or are we going to shift with the balance of donor funds coming? So the system really needs to be intentional in deciding that's what we want to do. And we're starting to see that more and more, I think. But that means integration. That means looking across the primary healthcare role. And Malawi is an example of that. HSAs are not just doing immunization. They're just doing a big part of it at scale. So, and then of course, all this drives the training, the supervision, and the advances in that. I would add one last point, which is hitting us more and more at Gavi. And, I've got a foot in the zero-dose implementation program, ZIP, that works in very unstable areas of the Sahel and the Horn of Africa, is also the role that CHWs are playing in terms of information. not just collecting information, and there's performance-based financing for that in some countries, not necessarily for immunization, but collecting information and making sense of it and helping to direct, for example, efforts towards zero dose, helping the micro plans to be more informed by local realities. That's something that requires really last mile, last kilometer presence. So if you look at our framework, IRMA, identification, reach, and especially in measurement, CHWs need to be equipped to be able to do that effectively and see what digital tools can do and where is a place for paper and where do we translate that. So I think all these things need to be part of system support. And then the other one is understanding the whole fit of community health workers. So that goes to this other theme that we have. And so I'll push back to Tom for you to talk a little bit to us about what we call the social anchoring of the community health worker programs.
Thanks, Eric. Yeah, I'll just quickly mention we only have about 4 minutes left. In terms of social anchoring, I think there are a couple of things we need to really take into account. One is, as we professionalize more and more community health workers, we need to maintain those deep connections that they have with communities. And we also need to do that with gender in mind. When we hire more paid community health workers, that can mean, it doesn't necessarily mean, but it can mean that we have more salaried women health workers, less exploitation of them, and the ability to bring health services a lot closer to women who make up the primary caregivers. Community health workers can help close gaps in service delivery to caregivers and make life easier for women. So part of the justification for this as well, of professionalization of community health workers and using them in this role, is the effect it has on women. Second, I think that we can both professionalize and pay more community health workers and preserve the good that we're having with volunteerism in communities. We don't have to totally get rid of volunteerism. And one way to do that is through two-tiered community health worker systems. And with these, a paid community health worker works with cohorts of volunteers who each work less than 8 hours a week. So the workload on the volunteers is very small. And we've seen excellent results from using these with systems for vaccination and other areas like nutrition and WASH as well. And for example, with the care group approach, one paid community health worker works with about 2 to 9 groups of about 12 volunteers, teaching them every 2 weeks to promote immunization. And then on top of that, they can have other functions, the paid community health worker, like in vaccinating children. We did a recent analysis of 63 programs and showed that programs that use the care group approach have achieved 12.5, 9, and 21 point better DTP1, measles, and tetanus toxoid indicator gap closure than programs that did not use the care group approach, and really excellent results in other indicators as well. And that echoed also a 2015 published study that found that care group projects had better coverage of measles and tetanus toxoid than other community health worker projects that didn't use this combination of volunteers and paid community health workers. Gavi actually plans to use its demand SFA funds to support countries in scaling this approach this year. So if you have an interested country, let us know. The Women's Development Army in Ethiopia with the paid health extension workers and the Women's Development Army volunteers is another example of that. And they basically, studies have shown that caregivers reached through that structure also had better immunization rates. Community health workers are also really important for community engagement. And we have seen a recent, I think it was a meta-analysis, found that community engagement basically improves vaccination rates about 2 to 4 points. So small, but measurable and statistically significant improvement when we have community engagement happening. Community health workers are great for that, reaching out to religious leaders, community leaders, and others. So let's go ahead and maybe close just with one question to all of you. What sort of guidance do we think would be needed for this? And do you know of other countries where we might want to focus in moving this forward more? And that's for all of you as attendees. So what sort of guidance do you think we should begin working on? And what are the countries where we should probably be doing more around this?
And the question, to add to Tom, the question really for everybody, but if there are still colleagues from the country teams, SCMs and so forth that are on board, because you're holding the reins.
So please raise your hand.
Maybe people are getting hungry.
Yeah, yeah.
It's been a long session. I don't know if we have.
Right at 12:20.
Yeah.
So we might need to organize something else around that to
Yeah.
begin looking with a smaller group of you in particular of what can we be doing to advance this more. So I want to thank Chifuniro. I want to thank Rebecca and all of you as participants. I really appreciate your having made the time for this. And I really think it is something that is exciting and that we should be paying attention to. And as we move forward with new technologies like the microarray patches, that might really open up the floodgates into where we can do this in a very cost-effective way as part of Gavi 6.0, for example. So thank you very much, and I really appreciate everyone's participation. Have a great day. Bye-bye.
Thank you.
Thank you,
Thanks,
everybody.
everyone. Cheers.
Thank you.